About an overview of chronic kidney disease management. I cannot encapsulate everything in the amount of time, and as a disclaimer, this is from the vantage point of a doctor practicing in the U.S., so I know that not everything I say is very practical, but I'll try to make this interactive, and hopefully you can gain something out of this. But before I begin, Sao Bunani. So anyway, so basically, so kidneys, a brief overview, I think you all know this. It removes waste products from the kidney. It removes extra water. And so basically, volume is a salt issue. Dehydration is a water issue. Your kidneys, if they're working properly, know how to manage both, if they're working properly. They also manage electrolytes. They also manage blood pressure through many mechanisms of action. And they also maintain blood pressure through many mechanisms of action. And they also maintain bone health because they convert vitamin D into active vitamin D, okay? And I did not include this on the slide, but your kidneys are also involved in gluconeogenesis, in helping make sugar. So that's why in people with kidney failure, your diabetics would oftentimes say their blood sugar is much better controlled because when your kidneys are failing, no gluconeogenesis, but also insulin is filtered through your kidneys. So with kidney failure, insulin hangs around longer, and you'll notice, your diabetics will notice that their blood sugar drops more often. So if a diabetic has lower blood sugar, so watch out for the kidney function. It could be that they're losing weight. It could be they've changed their diet drastically. In the U.S., that doesn't always happen, to be honest. But quite often, unfortunately, it's because kidneys are failing. Okay, so kidney disease is a silent disease, okay? So for the most part, patients are asymptomatic, and so I can't tell you how many times people say, "Doc, I'm urinating just fine, I feel fine, nothing's wrong with my kidneys." So I have the challenge of telling them that they have a problem that they don't think they have, okay? So even when patients may feel okay, they're not okay. So the basic functions on the previous slide start to slow down, okay? Blood pressure becomes more difficult to control, so that's why people with advanced kidney disease tend to have worse blood pressure, okay? So high blood pressure damages the kidneys, but bad kidneys make blood pressure harder to control. Almost everybody I saw on the dialysis unit yesterday had hypertension, high blood pressure. So, I think a lot of them presented to the ER with hypertensive emergency. Very likely they had advanced kidney disease, which whatever the etiology or cause for kidney disease caused their blood pressure to go very high. And so, it's kind of a vicious cycle, see? So as with worsening kidney function, your blood count decreases, your bones become more brittle. So people with advanced kidney disease have low hemoglobin, high PTH, and they're more prone to bone fractures, as well as bone pain, okay? And edema is more likely, and and electrolytes get harder to control. When kidneys deteriorate all the way, when the GFR are less than 15, it is no longer a silent disease. You have what's called uremia. Nausea, vomiting, dysgeusia, meaning that they have a bad taste in their mouth. Patients will say food tastes like metal, or food doesn't taste right. They feel itchy all over. They feel tired, weak, sleepy, dizzy, and now those are very non-specific symptoms, but taken in the clinical context with the labs and the symptoms that they're giving you, it probably is uremia. Now, patients often lie to me, telling me they feel fine because they don't want to do dialysis, but it takes talking to the family to see what's going on. So there's different stages of chronic kidney disease. GFR, there are 5 stages, okay? CKD1 is GFR above 90. Now, understand that you can have normal creatinine, but still have something wrong with the kidneys. If you have a lot of proteinuria, okay, your kidney function may be good at cleaning the blood out, but you still have some pathology at the microscopic level. Now, protein in the urine is still a problem. Blood in the urine, if it's not a urological cause, is still a problem. CKD2 is 60 to 90. CKD3 is 30 to 60. The vast majority of my consults are at that stage, with GFR between 30 and 60. Now, the earlier you catch kidney disease, the more difference you can make. Because quite often, patients are sent to me with advanced kidney disease, and to be honest, I'm kind of doing damage control and trying to buy time off of dialysis. But the earlier you catch kidney disease, get them on the right medication, the right diet, the fewer problems you have moving forward. Now, CKD4 is when GFR is between 15 to 30. That's when, when GFR less than 30, that's when the patient may feel okay, but things stop being okay. The blood pressure gets harder to control. They present to ER with hypertensive urgency or emergency. They become anemic. Their PTH or parathyroid hormone goes high, and their bones become very brittle. When CKD5, GFR less than 15, that's when everything I said gets worse, and the patient starts feeling uremic and needs to start dialysis. At that point, again, I know this is not not common here, but referral for kidney transplantation or dialysis. Okay. Now, creatinine is one variable that's used to calculate GFR. What's calculated in GFR is age, size, gender, and creatinine. So it's important to understand that a creatinine of 1, by the way, in the US we use conventional units. In the British system, or outside the US, they use international units, SI units. So a creatinine of 1 milligram per deciliter is equivalent to 88.42 micromoles per liter. So forgive me when I look at your labs, and I have to do some mental math and basically divide by roughly 90. So we use different units, I understand that. But anyway, a creatinine of 1 in a 20-year-old is very different from a creatinine of 1 in an 80-year-old. Because GFR goes down with age, okay? And so that needs to be taken into account. Don't be fooled by a low creatinine. The patients may still have some significant kidney disease and still be very prone to kidney disease. That's why an older patient is more prone to volume depletion and kidney failure than a 20-year-old, okay? A normal-looking creatinine can fool you, and after surgery, they can get acute kidney failure much more readily than a much younger patient. Now, patients in acute kidney failure are in a dynamic situation where if the creatinine is actively getting worse or actively improving, they do not have an established chronic kidney disease state, you see? So what I'm saying is, if the patient is actively getting worse, I cannot declare the patient as having chronic kidney disease 3 or 4 because there are too many moving variables and too many moving parts. Chronic kidney disease is defined when the patient is at steady state and is at equilibrium. Okay, so keep that in mind. Okay, so again, these are the risk factors. And again, I'm trained and work in the U.S. So diabetes, hypertension, obesity, family history, personal history of acute kidney failure. Even if patients can recover from acute kidney failure, they are more prone to kidney failure again in the future. Think of it as you cut yourself, you have a wound, even though you scab over and you heal, that wound is not, the integrity of that original skin has been compromised and you're more prone to injury in the future. So prior kidney failure is risk for future kidney failure. So you want to avoid kidney failure to start with, okay? Heart disease, heart failure, smoking is a risk factor. I would also add African ancestry. They've looked at all different races, whether it's in the sub-Saharan Africa or the African diaspora in North and South America. Okay, even if you control for all variables, diet, socioeconomics, I know everything. At baseline, there's much higher incidence of chronic kidney disease in people of African descent, and there are genetic reasons for that. There is a genetic finding called APOL1. It's recently found in the past 10 or 15 years. 1 in 3 African Americans is a carrier for that. It's prevalent in people in sub-Saharan Africa also, related to the exposure to the tsetse fly, African sleeping sickness. Anyway, if you have 2 homozygous copies of the APOL1, you're more prone to chronic kidney disease. It's available for genetic testing in the U.S. It's not cheap, so it's not available worldwide. But if it were available, I'm sure we find that it's much more prevalent. So other causes, and this is by no means a comprehensive list. I know this is not practical for everybody, but briefly, glomerular diseases, lupus. Lupus, especially in people of color, is much more likely to cause lupus nephritis. HIV-associated nephropathy, I know that's very common here. FSGS, or focal segmental glomerular sclerosis, they're primary and secondary causes of FSGS. IgA nephropathy is common in people of East Asian descent, not very common in people of African descent, and vasculitis. Things like ankylosing, or you probably heard an old term, Wagner's granulomatosis, if you remember that from medical school. Inherited conditions like polycystic kidney disease, that's That's diagnosed by ultrasound, by imaging studies, cysts, and that's, by the way, that's universal across all races, so it happens, that's common in equal distribution everywhere. Autoimmune conditions like lupus and ANCA vasculitis, medication causes, NSAID use can cause it. Amphotericin B, which is a very good antifungal agent, but it's notorious for causing kidney damage. Obstructive mechanical issues, severe kidney stones. If you have bilateral urinary blockage and with kidney stones, that's a problem. Uncorrected bladder obstruction, whether it's from a large prostate or bladder obstruction, like for example anticholinergic agents, which cause a lot of older men to have trouble urinating, or if you can have gynecological obstruction, whether it's a cervical cancer or things of that nature. That chronic obstruction can lead to a kidney failure. So, causes of acute kidney failure. If you don't reverse it soon enough, you cause chronic damage. So you want to diagnose the cause and try to reverse what you can while you can as quickly as possible. So anuric is 100 cc's or less urine, oliguric between 100 and 400, non-oliguric is between 400 and 1 liter of urine. Normal urine output is between 1 to 2 liters a day, depending on your size. So if you any cause of acute kidney failure, the more urine you make at the outset of the condition, the better your prognosis. You see, so someone who, for example, has gentamicin poisoning is much more likely to have non-oliguric kidney failure. I had one patient who had received 200 milligrams of gentamicin by mistake, and he had acute kidney failure, which required dialysis, but he recovered because luckily he was making good urine. On the other hand, someone who had severe septic shock or cardiogenic shock or any kind of shock whose urine output stopped entirely, it took much longer for that person to recover, and those patients have much lower, have a much worse prognosis. Okay, so in a nutshell, for my consults in the hospital, pre-renal kidney damage means decreased perfusion to the kidneys. So, okay, most of the time, that's volume loss, nausea, vomiting, diarrhea, or sometimes if you have severe heart failure, the patient may be volume overloaded, but very poor blood flow to the kidney. So it's important not to assume that poor perfusion to the kidney is due to volume depletion. You must look at the patient first, you see. Sometimes the patient just needs some inotropic support to improve blood flow from the heart to the kidney. Some people make the mistake of giving IV fluids to everybody. That's a mistake. Intrinsic is where you have intrinsic damage to the kidneys. Acute tubular necrosis is the #1 cause that you see, whether it's any number of causes. Septic shock, cardiogenic shock, contrast nephropathy, whether it's from a CAT scan contrast or heart catheterization, which involves contrast. Rhabdomyolysis from a crush injury from muscles, hemoglobinuria, which you can see in malaria, by the way, and there are other things like acute interstitial nephritis. Medications can cause it, and infections can cause that. Infections including tuberculosis can cause nephritis, and of course vasculitis. Post-obstructive, roughly 10% of these patients, sometimes it's just the patient just needs proper drainage of the urine, whether it's a good proper Foley catheter placement, or they probably need tubes to drain the ureters because the cervical tumor or something is causing an obstruction. Or it could be a ureteral obstruction or stricture caused by prior traumatic surgery, for example. I've seen that before also. So it's important to look at the patient. I've once dialyzed a patient who just needed a proper Foley catheter placement. After a Foley catheter went in, 10 liters of urine came out, no more dialysis. So it's important to look at the patient. Okay, so this is schematic diagram of what we just spoke about. Okay, so this is a busy slide, so don't worry about this too much. There's no universal agreed upon definition of acute kidney failure. Okay, for example, okay, there's something called the Rifle criteria. To be quite honest, I don't look at a patient and say, Mrs. Jones, you do not meet the Rifle criteria, you don't have acute kidney failure. Acute kidney failure is anytime there is an increase in creatinine over a short period of time, and or an acute decrease in urine output over a short period of time. Most of the time, patients get both, rise in creatinine, drop in urine output. But either or can happen. So you don't have to have both. Either or, any of those options is a possibility. Rise in creatinine, or drop in urine output, or sometimes, most of the time, it's both. Okay, so pre-renal, understand that in pre-renal, your tubules still work. So you have the glomerulus, and then you have tubules, which do all the hard work of concentrating the urine. So I'm sorry, this is a busy slide. I'll just break this down briefly here. So in pre-renal, where your tubules work, your kidneys still know how to concentrate urine. So your kidneys are smart. They try to extract all the salt, the sodium out of the urine, right? And so if you're trying to concentrate urine, your urine sodium is very low, okay? And because the urine is very concentrated, your urine osmolality is very high. And the urine under microscope, and that's just by looking at a microscope, is bland. You may see some hyaline cast, but otherwise it's bland. Acute tubular necrosis is where the tubules do not work. And so your tubules cannot concentrate urine, therefore the urine sodium is high, and the urine is not well concentrated because your kidneys do not know how to concentrate urine, and you have muddy brown casts and granular casts. Okay, so the key is here that in the pre-renal, your kidneys still know how to concentrate urine, so they're going to extract all the sodium out of the urine that they possibly can because you're in a volume depleted state. Okay, now something that I did not include up here is an entity called hepatorenal syndrome. Hepatorenal syndrome is where you have liver failure and kidney failure simultaneously. Now, what's confusing is that your kidney parenchyma is intact and your kidneys still work. Your kidney tubules still work, so your urine sodium is still very low. But the difference is, in hepatorenal syndrome, your urine sediment is very bland. But the difference between hepatorenal and pre-renal is that the solution to pre-renal is giving volume resuscitation. In hepatorenal syndrome, you give volume resuscitation, nothing changes, nothing improves. It requires other therapy. Okay, acute glomerular, I won't go through all this, but acute glomerulonephritis, you see dysmorphic red cells. The red cells are kind of convoluted, and you have red cell casts and proteinuria. Acute interstitial nephritis, you have white cell casts in eosinophilia, and post-renal, remember, your tubules don't work very well. So again, your urine sodium is high, and because your tubules cannot work, you see. Okay, so CKD complications. As kidneys get worse, all of these problems get worse. The number one cause of death for CKD patients and dialysis patients is cardiac. If you go to any hospital in the U.S., you hear code blue or whatever the equivalent is here in Eswatini, because number one, the rapid shift in fluid and electrolytes stuns and stresses the heart, but also you have just more atherosclerosis and endothelial damage at the microscopic level, which causes increased risk of cardiac death, you see. In the U.S., there are 40 million people with chronic kidney disease, less than 1 million patients on dialysis. The reason for the drop-off, the vast majority of those people die from heart disease or heart arrhythmias, you see. So it's very important to check the cardiac health of your CKD patients. Hypertension usually requires multiple medications. Again, worsening CKD requires more blood pressure medicines and diuretics, because with fewer nephrons to do the job, you have a harder time processing and getting rid of the salts, you see? And so you need more diuretics to help get rid of the salts, okay? Diuretics are not a very powerful blood pressure medication, but getting rid of salts out of the body is necessary to help control blood pressure. Now, with worsening CKD, again, GFR less than 30, you need, blood transfusions. If unfortunately, I know that erythropoietin agents are very hard to come by and they're very expensive. But up until the 1980s in the U.S., dialysis patients had to regularly get blood transfusions because that was the only way to keep the blood count up, you see. Metabolic acidosis. With worsening nephrons, you're much less able to titrate the acid and get rid of acid, so quite often they need bicarbonate tablets to neutralize the acid. Secondary hyperparathyroidism, high PTH causes weakened bones, much more bone pain, much higher risk of fracture. And of course, electrolyte abnormalities, high potassium, worsening acidosis, high phosphorus, and so forth. Okay, so indications for dialysis. One of the things I learned in training was AEIOU. So basically, acidosis for people who, when the acidosis is refractory or resistant to medication management, electrolytes. Hyperkalemia is an emergency. When potassium is, and I'm using American units, or above 7 or 8 or something, that's emergency dialysis. Sometimes we also can dialyze for high magnesium or high calcium, not very common, but high potassium is the most common reason. Intoxications. In the U.S., we have a lot of people who have salicylate toxicity, aspirin overdose, ethylene glycol toxicity, or lithium, or metformin, which is used for diabetics, or theophylline, or lithium. Lithium toxicity is a big one also. O for volume overload. If the volume overload is refractory to diuretic management, then dialysis is necessary. Uremia is a clinical determination. So understand that uremia is not diagnosed by laboratory levels. You see, so you can have a BUN, a blood urea nitrogen level of 30, but still be uremic. Because if I have a patient who has very low muscle mass, the creatinine and the blood urea nitrogen will be very low because they have very low muscle mass and they're very malnourished. But that patient can still be uremic, so uremia cannot be diagnosed based on labs. Conversely, you can have a very high blood urea nitrogen caused by a gastrointestinal bleed, or because of steroids. Both of those things can raise your blood urea nitrogen, but they may not be uremic. You see, so it's important to not judge uremia based on labs. You see, now uremia, as I said before, low appetite, fatigue, nausea, vomiting, excessive itching, dysgeusia, bad taste in the mouth, failure to thrive. That's uremia. Now, uremia, it's a miserable thing, but emergent requirements for dialysis is uremic pericarditis. You would hear a pericardial rub on exam. The reason that's an emergency is because you could bleed into the heart, cause tamponade, and the patient could die from a cardiac tamponade. Also, uremic encephalopathy. I've seen a patient who refused dialysis. She was encephalopathic, and she started seizing like crazy, and then she died. So now in the U.S. we don't have too much uremic frost, but that does exist. Unfortunately, I don't have any pictures. So general health advice: control blood pressure and diabetes. Diet, exercise, appropriate lab tests, get a family history, and appropriate medications. Other risk factors: smoking, avoid smoking, lower cholesterol, and so forth. Minimize nephrotoxins. Minimize NSAID use. NSAIDs are very effective anti-inflammatory agents for a lot of different types of pain, but over time they can cause not only stomach ulcers, but they can also lead to chronic kidney disease. Minimize IV contrast. People with weakened kidneys are more prone to kidney damage, and it's kind of like adding insult to injury with IV contrast exposure. Aminoglycoside antibiotics, they're very effective, but gentamicin and amikacin are notorious for causing worsening kidney disease. Amphotericin, cisplatin, which is commonly, all the platinum drugs, which are chemotherapy drugs, are notorious for causing kidney damage. Calcineurin inhibitors like cyclosporin, while that's used for a lot of, ironically, while it's used for a lot of kidney diseases, cyclosporin itself can cause fibrosis in the kidney and cause worsening damage. Of course, check basic chemistry labs, check urine. Checking urine protein and urine albumin is key. Again, you may have normal creatinine, but have a high urine protein. That still requires a lot of attention, because the worse the protein in the urine, the more quickly that kidney will burn out. Think of protein in the urine as a fire burning through the kidney that you need to extinguish. You see, the worse the protein in the urine, the worse the kidney health. Even if the kidney labs on that day look okay, in a few years they will not be okay. So it's important to act quickly. Okay, and of course check for hematuria. It may or may not be microscopic. As I said before, intact red cells suggest a urological problem. Could be as simple as Foley catheter trauma, or it could be or dysmorphic cells, which are convoluted red cells, is probably a glomerulonephritis of some sort. So, as I said before, if you have urine, even if your urine albumin to creatinine ratio is 30 or is 30, it still requires urgent attention. Many lab tests are needed, can be diagnosed. I know that's not a luxury that everybody has. And as far as kidney biopsy, I know that's not a luxury everybody has, but kidney biopsy can sort of sort out the diagnosis. Let me give you an example. I had a patient who I thought had diabetic nephropathy because of her family history, but I did a biopsy. It turns out she had IgA nephropathy. Very different treatment. I had a patient who had HIV as well as diabetes. I did a biopsy, and it turned out he had diabetic nephropathy instead of HIV-associated nephropathy. The reason that made a difference is because part of the treatment for HIV-associated nephropathy is not only antiretrovirals, but also steroids. But if I'd given this diabetic some steroids, I would have made his sugar worse, you see? So that's why the kidney biopsy ideally helped me sort out the diagnosis. Target blood pressure is 120/80. For the general population, it's not that strict, but for patients with advanced CKD, you want it lower. Less risk of kidney failure, less risk of CKD progression, less risk of ischemic stroke, and there's less risk of cardiac issues also. Generally speaking, anybody who has CKD or proteinuria will benefit from being an ACE inhibitor or ARB, as well as SGLT2 inhibitor. I don't know what the equivalent here is in Eswatini. Dapagliflozin, canagliflozin, empagliflozin. That was originally marketed to diabetics, but they quickly learned that for anybody with any type of chronic kidney disease, it decreases dialysis by up to 30%, and it decreases hospitalization by up to 30%. It decreases cardiac mortality also by up to 30%. Now, the cause of kidney disease will also drive the treatments, as I said before, and that'll determine whether the patient gets steroids, no steroids, or alkylating agents. Okay. So albumin is the predominant protein that's filtered by the kidney. Of course, your kidney has mechanisms that reabsorb and break down the protein, but in the state of proteinuria, in the state of severe proteinuria, those mechanisms are overwhelmed. You see, and nephrotic range proteinuria is when you have more than 3.5 grams of protein. Nephrotic syndrome is when you have 3.5 grams of protein plus high cholesterol, okay, plus edema and plus low albumin. So not everyone who has nephrotic range proteinuria has nephrotic syndrome, but there's some overlap. Okay, so so proteinuria. I'll just go through this quickly. Okay, a 24-hour urine collection is ideal for diagnosing it, but it's not very practical for a lot of reasons. Sometimes I can assess a patient's proteinuria by doing a spot urine protein to creatinine ratio, or doing a spot urine albumin to creatinine ratio. And the reason I say it's not ideal is because there is a diurnal and a nocturnal variation in terms of protein production in the urine, you see? So the 24-hour urine collection helps average everything out, but sometimes a spot urine will do the job just fine. Okay, so this is not an exhaustive list, but I'll just go through this briefly. Members nephropathy is diagnosed by biopsy. Okay, primary is 70%, but 30% of the time you could have a secondary cause, whether it's NSAID use or infectious use. If you have a patient with an adult patient with membranous, you must look for a solid tumor in neoplasm. So that's key. Diabetic nephropathy is the most common cause of proteinuria in the U.S., probably also worldwide. So minimal change disease is the most common cause of proteinuria in children. For the pediatricians in the group, if you have a young child with anasarca, who's very edematous and has a lot of protein in the urine, you'll be forgiven if you just start the patient on steroids, because 95% of the time you'll be correct. Just give the patient some steroid dose and steroid taper, and you'll see the anasarca disappear overnight. It can come back, but it's luckily it's a very easy problem to treat. FSGS, or focal segmental glomerulosclerosis, again diagnosed by biopsy. First line is steroids, but 30% of the time you need something stronger like cyclosporin. Secondary cause of FSGS, HIV nephropathy. The most common, that's common in people of African descent, by the way. It's not common anywhere else in any other race. It's uniquely common in people of African descent. Okay, obesity can cause that. Okay, sickle cell disease can cause this, as well as heroin. That's not probably not a problem here in Eswatini, luckily. And medications like pamidronate, which is a common bisphosphonate used in the U.S. Multiple myeloma can cause proteinuria that requires chemotherapy from hematology. High blood pressure, by the way, by itself can cause some degree of microalbuminuria. Okay, so that's a possibility. There's a pathology diagnosis called membranous glomerulonephritis. It can be caused by a lot of different things. And now the labs, if they're available, you can check complement levels, C3, C4 levels, HIV labs, hepatitis B or C, syphilis screening. Syphilis can cause a secondary membranous nephropathy, by the way. Okay? And of course, protein electrophoresis. So I check a bunch of labs if I see a patient with protein. You need to be wise. about checking, not checking too many labs. I realize that, but if you do screening properly, you can order labs strategically and order them on the right patient at the right time. So treatment, and basically ACE inhibitor ARB with SGLT2 inhibitor, that's indicated pretty universally for anybody with chronic kidney disease and or proteinuria. Again, that decreases the likelihood of dialysis, that decreases hospitalization, and decreases a lot of bad things, and that's irrespective of whether or not the patient has diabetes. Please understand that. In the U.S. and in Europe, there's mineralocorticoid antagonists are becoming more frequently used to help. It's called finerenone, or Kerendia is the brand name in the U.S. It decreases kidney failure and diabetic nephropathy also. Therapy is very disease specific. So whether they require steroids or alkylating agents, the treatment for membranous nephropathy, by the way, is cyclophosphamide or Cytoxan, which is the brand name in the U.S., or as well as immunosuppressants. Again, it depends on what the disease is. These are patients who are all immunocompromised. When you urinate a lot of protein, you lose a lot of immunoglobulins. So you're immunocompromised. So it's recommended that they be properly vaccinated. Also, I have a very low threshold for treating them with antibiotics should they get an infection. Because when you lose immunoglobulins, you are more prone to infections from encapsulated bacteria, you see? And they're much more prone to sepsis. So keep that in mind, okay? Increased risk of coronary disease. More proteinuria increases the cholesterol, which increases their risk of coronary disease. So it's very common for these patients to be on cholesterol medication, irrespective of their age, okay? As well as to be on aspirin also to prevent coronary disease, okay? Membranous nephropathy, because these patients regularly put out like 10 grams of protein, it can cause renal vein thrombosis, which can necessitate Coumadin therapy. Okay, so malaria, this is something that I've never seen clinically, but I did read up on this. Okay, malaria can cause hemolysis, hemoglobinuria, it can cause hemoglobin cast nephropathy, and cause ATN, and there's a term called black water fever, because they're febrile from the malaria, but they also have kidney damage, and their urine is very dark from the muddy brown casts. Very high mortality. So if you treat the malaria aggressively, you can decrease the likelihood of kidney damage. You can on some occasions get nephrotic syndrome or nephritic syndrome from malaria infection. Nephritic syndrome is red cell casts, some proteinuria, high blood pressure. Okay, but these patients do not necessarily all have nephrotic range proteinuria. Plasmodium falciparum, which is very common in Africa, is much more aggressive than Plasmodium vivax or Plasmodium ovale. So it's much more aggressive. Okay, and as with anything else, if you don't treat early, you get chronic damage and CKD progression. Now TB, which I know is common here, is it causes kidney damage indirectly. So basically TB can infect the glomeruli, cause granulomas, and they can bleed. Okay, so you can get a lot of painless hematuria. You can also get sterile pyuria. Sterile pyuria means the urine has white cells in it, but no bacterial infection. Okay, so renal TB is common if you know what to look for also. And because of the damage, it can cause a lot of kidney stones, calcification of the kidney, as well as urethral obstruction. Now, anytime you have that kind of structural damage, you increase the likelihood of chronic kidney disease progression. And that's pretty miserable if it's not caught in time, because in men it can cause epididymitis as well as a lot of scrotal pain, and in women it can cause infertility also. Surgery is used to treat structural abnormalities, and by the way, TB can also cause interstitial nephritis in terms of causing white cells in the urine and just causing a lot of inflammation. So TB does not cause people on dialysis, but can certainly cause a lot of damage also. As far as treating TB, I think you know that better than I do. Now, for high blood pressure management, okay, ensure proper cuff size. It's important to not have the cuff too loose or too tight, okay, because otherwise you get inaccurate measurements. Screen for blood pressure, make sure there's no white coat hypertension. People get nervous or angry coming to the doctor, so blood pressure goes up. Okay, include all possible herbal supplements. People take a lot of weird stuff. It can raise your blood pressure. Screen for alcohol use, tobacco use, and caffeine use. Okay, NSAIDs, oral contraceptives, can raise the blood pressure. Okay, steroids and antidepressants can cause that. Cocaine and methamphetamines, a problem in the U.S. that can cause that too. what I usually do, I get blood chemistry and check the urine also. Risk factors for blood pressure: African heritage, family history of hypertension, and high salt intake. So we can't change our family history, but you can cut down the salt. Okay. Okay, by the way, this is key. When you start ACE inhibitor or ARB, it is very common to see the creatinine rise by 30 to 40%. Don't panic, that's normal. If the creatinine doubles, then that's a problem. But if you see a bump in the creatinine after you start, that's okay. Over the long term, that patient is much better off on that medication than off that medication. So a rise of 30 to 40% is actually okay. Okay, secondary causes: sleep apnea. If you have obese patients, sleep apnea raises blood pressure. Other causes, there's some hereditary causes. Renal artery stenosis can cause this. In the heart, you can have what's called aortic coarctation. That's where you have high blood pressure in the arms, but not the legs. That's different. You have some endocrine causes. High aldosterone can cause that, and there's some other causes. And so when people are in pain or have severe anxiety, that can also cause high blood pressure also. Okay. So hypertension. Okay, so briefly, diet, exercise, nothing replaces that. If the patient has a blood pressure of over 160 systolic, I try to start on 2 medications, and over 140, I try to start on 1. I try to minimize pills as much as possible, but some people, they just need medication. So if the patient has protein in the urine, or diabetes, or heart failure, or CKD, I try to do ACEs and Rs. Of course, don't give it if they're pregnant or breastfeeding. That's key. If the patient has cardiac arrhythmias, I use beta blockers. If they're edematous or have fluid overload, they're diuretics. If they have advanced heart failure or high aldosterone levels, then use aldosterone blockers. My goal for the blood pressure is less than 125 over 75 or less. Hypertensive emergencies, and talking to Dr. Poli, I like my carbamazepine drip. It's very effective. They may come in with chest pain and blood pressure of over 180 systolic. You don't want to drop it too fast. You want probably 10 to 20% reduction in the first hour, and another 15% over the following 24 hours. Aortic dissection, which is a surgical emergency, depending if it's type A or type B. That systolic pressure needs to be lowered quickly. Last slide. For hematuria, basically, okay, direct microscopy is superior to urine dipstick. A urine dipstick can be positive from red pigments, like if you take rifampin, which causes the urine to turn red, or if you have rapid myolysis from myoglobin or hemoglobinuria, you can get a false positive for the urine dipstick. That's why it's important to if you have the facilities to look for red cells in the urine, rather than just rely on the urine dipstick. Glomerulonephritis, which is basically any kind of inflammation in the kidneys. Proteinuria, red cell cast, and dysmorphic red cells. Nephritic syndrome, I said, is high blood pressure, red cell cast, and protein in the urine. RPGN, or rapidly progressive glomerulonephritis, that's a pathology diagnosis where the kidney biopsy shows crescents and a lot of very active inflammatory disease on the kidney. These patients are very sick. They have rapidly worsening kidney function, and they have severe hypertension, and they have systemic illness. Glomerulonephritis, lupus, post-infectious GN. This used to be called post-strep GN, but I've seen this happen with staph infection. I've even seen this with Epstein-Barr virus. Because in the U.S. we treat everything with antibiotics, rightly or wrongly, we see this much less often, but it can still happen irrespective of proper antibiotic therapy. Okay. Then ankylosing is another one. Alport is a genetic inherited disease where you have a defect in type 4 collagen, which affects the ears and the kidneys. It does progress towards chronic kidney disease, but there's no rapidly progressive thing. It's an inherited disease, but it can lead to kidney failure. Like I said before, non-glomerular hematuria, infection, kidney stones, neoplasia, catheter trauma. This is probably the most common. And cystic diseases. Patients who have polycystic kidney disease, the cysts can bleed and cause blood in the urine, and treatment depends on the underlying pathology. And 9:32, I'm done. Thank you very much. We can talk about
Thank you, Dr. Hos, and thank you so much for a very insightful presentation. One is a request. If it is possible, if you can leave your presentation for us for future reference, that's going to be great. The second one is how low, when we should worry when the creatinine is very low, and what can be done? What does that mean? Sometimes we find patients with a very low creatinine. That's the second one. Is with minimal change, usually we have the challenge of doing biopsy. So how can we have a high index of suspicion of minimal change in the absence of biopsy?
Yes. Okay. Okay. If I heard you correctly, sir, doctor, I think you said, how in the absence of the biopsy, how can we have a high dose, a clinical suspicion for minimal change in disease? And the first question says, when do you worry about a low creatinine? Okay. Okay. So low creatinine. First of all, if there's a family history, okay, that patient probably needs closer observation. But the practical answer to your question, if there's protein and or blood in the urine, that patient needs more diagnostic attention and closer observation. And I would also get if there's a family history and or history of high blood pressure that's premature for the age, I would get an ultrasound if that's an option, okay, and to check the urine also aggressively. And so again, if the patient has low creatinine, if there's a strong family history, and if there's high blood pressure, and if there's protein in the urine and or blood in the urine, that patient needs more attention and more workup. Get an ultrasound, check control the blood pressure more preemptively and aggressively, and do as much diagnostic workup as is available. Now, as for the second one, if it's a child, 95% of the time it's minimal change disease. As far as an adult, here's what I would say practically. Go ahead and order what labs you can, and start with steroids, because okay, even though we have kidney biopsy available in U.S., I cannot do a kidney biopsy because if the patient's on Eliquis or Coumadin or Plavix for any reason, I can't do biopsy. So I have to start with steroids and see if they get better. If they get better, I'm good.
The patient is good too.
Yes.
Thank you so much for the presentation. I just want to ask, at what stage of CKD do you give the calcium and the vitamin D? Do you check first the levels, or you get to maybe stage 3 when you start giving
Start giving the what now?
vitamin D and calcium?
Okay. Okay. Good question. CKD3, I would say probably GFR around 45 or less. That's when you start becoming vitamin D deficient, and when the proximal tubule stops being less able to convert to active vitamin D. I would also mention that with worsening CKD, the proximal tubule becomes less able to make erythropoietin and convert vitamin D. So your CKD patients will all be anemic and have high PTH. Okay? That's one way you can distinguish between someone who's probably acute versus advanced chronic disease. But when patients are sent to me, I have the luxury of checking everything on anybody. But for I guess in a resource stressed area, I would say GFR 45 or less. So.
Thank you. I think we.
Yes. Sorry for taking the time.
It's fine. Thank you very much, professors. I think you made your presentations quite easy to digest. I think some of the information will be used immediately from here.
Yes.
from here, like they are going to the WhatsApp right now. So yeah, can you please clap for it? Maybe just to, on top of what Dr. Paulus was saying in terms of the presentation, I'll just comment. I think maybe the specialist in the different department that you are at can have your contact so that there's the communication.
Sure.
The communication is easy now.
Yeah.
So even if we are breaking the US, can still help us.
Okay.
Some
No, we would,
places,
I'd love to have the contacts,
Yeah.
email.
Yeah, email, WhatsApp, whatever. Yeah, so can we close now? Dr. Paulus, please close for us.
Let us pray. Father, Lord, we thank you for this great time of fellowship together. We thank you for the knowledge that we have acquired. Give us grace to implement and help our patients. Bless the rest of the day in Jesus' name. Amen.
Amen. Amen. I'm so proud of you. Thank you. Thank you. Thank you very much.
Thank you for having us.
Thank you.
Thank you so much for coming.
Thank you. Thank you. Thank you so much.
It was a great
We enjoyed it. Thank you so much. Hey, thank you. Thank you. God bless you. My friend Dr. Kwali Kwali. Good to see you. Good to see you. Thank you for your welcome yesterday.
Thank you.
We really appreciate it. Thank you. Thank you so much.
You can call me anytime. I mean, my mentors let me do that.
I'll come down as soon as I finish here.
Yeah, when you finish, yeah.
Hey, yeah, good to see you again. Good to see you. Thanks for yesterday for introducing.
Thank you.
yourself.
Thank you so much.
Alright, you come and just
Yes.
to
I want
introduce them to the CEO.